Welcome to our podcast series, Getting to the Core Issues. Hello, I'm Joanne Bellata.
And I'm Marianne Harmston.
Each segment, we will interview healthcare innovators whose models will help transform the healthcare delivery system and provide solutions to the healthcare puzzle. The theme of this podcast is Better Healthcare in the U.S. Is this possible? Comparative Perspectives to Guess So. Our guest today is DiPrete Brown. For over 30 years, Lori has traveled the world with the goal of improving and educating on the topic of global health. She has been a leader in global education and outreach at the University of Wisconsin-Madison, including designing curricula for the Global Health Institute and supporting the development of faculty-led field courses and internships around the world. She leads GHI's Quality Improvement Institute. Lori's work at the University of Wisconsin-Madison is informed by 15 years of experience with international agencies, including the U.S. Peace Corps, USAID, Pan American Health Organization, World Health Organization, CARE, and Save the Children. She has collaborated to strengthen systems of care in 15 countries around the world, including Costa Rica, Guatemala, and Mexico, and others. Welcome, Lori.
Thank you.
A couple of points I wanted to make. The ABIMF had put together a program called Choosing Wisely, and it was based on a study, I think that was done by the Commonwealth Fund, that said 30% of all the healthcare spending in this country is for unnecessary tests and treatment, which is waste. And, part of their project, which, I'm leading a campaign in Rhode Island, is to get physicians and patients to have conversations about unnecessary treatment and waste. And back to your point, too, about, the qualification levels of some of the people we put in place to deliver healthcare. An example I had was I was working with a client doing some consulting work at a methadone clinic. And the state requires that they have in this health home model that they've created, which is they're trying to create almost like a patient-centered medical home for people with addictions. But the qualifications that they put into place for a case manager, basically it wasn't even a full case manager. It was someone to help the patient find housing, get a job, find the ability to apply for food stamps and other things. They wanted a master level person.
Yeah.
It's ridiculous because
that's the same as
master salary and benefits. And when really you could take anyone maybe with even a high school diploma, train them appropriately. It's a matter of just making phone calls and doing coordination and documentation. And so it was excessive. I think a lot of what's happening in the healthcare system, and maybe you can comment on this, is there's a whole economic engine that has been built around healthcare. And it has built for the treatment of, conditions, but not necessarily for prevention. And trying to unravel that is very difficult because there's a lot of people that are looking at it as a form of jobs.
I think this is a really important point, and it's more than just this task shifting aspect. I think, we already have a CNA model, and we have 2-year associate's degrees. I think credentials are very important, but you need to think systemically about it too. If physicians are not trained, that it's better to use their, clinical acumen than make 100% sure with a test, or they're being trained to use the technology and to do the tests. Even in nursing, it's become much more technology. So again, over in the international settings, and some of my medical and nursing and pharmacy students who do global internships, one of the things they see is how people have this clinical judgment and skills that allow them not to use all the other unnecessary medicines. And then this idea of a patient navigator, I think that, that's one problem. Usually policies that are great start out mediocre. So this is a great idea. The credentials were wrong. You got something to start with, and then you move from there rather than, beating ourselves up about that, right? And then I would say, again, QI can be your tool, because if you can get permission to compare the performance of a master's level person and someone with an associate's degree and X hours of training, and you show the quality is the same, the whole argument that keeps that scaffolding going, that again, you've got a young person who wants to do this work, they've got a lot of student loans, their whole quality of life in getting this extra education, even if you have an easy way to do it, it's costing them a lot too. it has a lot more impacts than just the healthcare. I think if you do that QI study, it's hard for people to say you can't use the worker with less, fewer years or hours of clinical training. So I think, and it's also, you don't want people to go too fast, because in a setting where we have a lot of profit-making players, they could try to use a middle schooler, right? And work from the bottom up. So you don't want these to turn into minimum wage jobs where you don't have quality either. So it's not crazy to think about credentialing, and finding the happy medium is what's hard. And I think, a lot of people think that competition and free market approaches will get us there. And I think you're giving an example where the regulation is part of the problem in a way. But I think regulation, and I think it can be, and I think it's important for everybody to acknowledge that, but they also can be part of the solution, because the healthcare market is an imperfect one. We're never going to get to a situation where patients or clients or the families around them have the health expertise to make decisions or to determine what things are worth. I mean, we're pretty shielded from what our healthcare costs. I think my kids probably wouldn't mind me saying this since they're all adults now, but I remember we were faced with an acne treatment, an acne med in 8th grade. It was like $75 for the prescription, and I was supposed to renew that every 2 months. I had to pay $5 because I had good insurance. So there was no cost there. There was no real willingness to pay check on that, which if it was a car or if it was a toaster or anything else, it would be. So we're not functioning like the free market. In the free market, somebody can't control how many toasters I make, how many you will buy, and what the price is. That would be a distorted market. Toasters would cost $1 million. Right? So right now, that's how the healthcare is. Providers, the system, which is mainly a good system with very ethical people, controls supply, demand, and price. That's not a free market. That's a distorted market. And if we can save the free market consumer choice and the quality that comes with the free market, but having some regulation, we can provide efficiencies. I think reasonable credentials and standards are what we want to get at. QI studies can help with that. I think consumer choice, and within a more regulated, kind of even a single payer system, if we went to that. And I know not everybody's ready. I don't think we can get there from here. But if we were not going from somewhere and just wanted to get there, that's where I would start. We would still have a lot of choice, because you vote for your elected officials, you have malpractice things in place, and quality education. You can invest in quality education for all of these levels and solid internal QI programs. You're going to have the quality that you want. But I think consumers need to be educated also, in addition to, if you have this chain of workers with different levels that we're imagining, the consumer is part of that. And having more knowledge about how to manage your basic health and how to help your family members. We already have students learning about how, we have the hours in schools to do that. Does anyone teach young people about how to help their parents, manage healthcare? It's just like financial education. We're starting to do more of that. How do you have a credit card? How do you cook? The adulting stuff, right? That is a big joke in our society. Managing healthcare and getting health insurance is part of that. And actually, we do a little bit of that at UW-Madison. One of the classes I teach about public health, we go into, how are you going to get healthcare? Does everybody in your family have it? Do you need help with this? They don't know how to do it.
As you just described, the free market approach right now is a little bit convoluted in that it's, like you said, it's from beginning to end, it's controlled in a format that really isn't the way the free market works. So considering that, you've also described better formats that you've seen in other countries. Do you really think that in America, are you also describing the fact that possibly for a certain either percentage or segment of the population, that there will be options so that you have a part of it as a community-based with more flexibility of choice, and then part of it going with this is a huge percentage of our GDP, huge corporation. Yeah. Mm-hmm. You did mention the educational costs. So and I remember once I used to insure a medical college, I was a risk manager, and I asked one of the residents, I said, I just don't understand why they insist that residents work a full weekend without any rest. Yeah. I mean, it seems to be putting the patient at jeopardy. And they said, well, I said, what is the thinking behind that? And they said it really simply is that they had to do it. the other physicians that was, and so we're going to have to do it.
Yeah. Well, there's a workers' rights issue for residents. The other thing about that, I have to comment on that because I'm really interested in diversity in our health sciences education. Mm-hmm. Besides that being possibly a labor abuse for residents in the worst case scenario, it affects who can be a resident. So suddenly someone with parental responsibilities, whether male or female, or other kinds of care responsibilities, it's harder to get into these tracks, or the way you organize your life around it. So many professions allow you to have, a part-time training. And what they kind of say within the medical field, I think this is changing a little bit, but, the residents have to learn how to do this 24/7 thing because they'll have to do that as a physician. Sort of, but not really for 3
Not
years.
really.
So, and it's not really a healthy lifestyle that they're learning. Right. So, yeah, I think these are little, again, distortions that happen in the middle of a system. And I have so much respect for the medical profession. And I think people are in a system. A system can behave differently than every single individual in it. Any of us, if offered the opportunity to have an economic empire where we can control supply, demand, and price, we'd all take that job, okay? Mm-hmm. It's a terrible thing. But we need to structure it more ethically so that the ethical individuals can do what they want to do. I think a lot of healthcare providers are dissatisfied. I have a colleague here who is an emergency medicine physician. And she said one of the reasons she chose emergency medicine is because it was the only field she saw where she knew that she would never have to turn away care for a patient. And the idea of turning away care was outside of her personal ethic.
That speaks to the integrity of not only the person, her family. I mean, that's what you would hope.
Yeah,
every physician would, or every person.
Well, we've created a system where they would have to violate their personal ethic on a daily basis.
Right. Exactly.
And and that goes for nursing and pharmacy too. I don't mean to elevate physicians.
Mm-hmm. Because even at the clinics, if they lost coverage with Medicaid and they didn't have any other coverage and didn't have any cash to pay for the services, they were what they called dosed down. Got to dose them down until they could release them and put them back on the street. How sad is that?
Yeah. So I was using an example like this from Uganda about diabetes care because, you have diabetes just unfolding with no care. And I said, you have physicians who know what the treatment is. And instead people are going to have, these kind of really, really bad progression. And somebody raised their hand and said that happened to me in rural Wisconsin when people I can't keep them on their insulin. It's just too expensive. It's really heartbreaking for people. And, you get people and then they'll start telling stories about, this one woman, I actually was giving her money for food for a while. It's like they're trying to solve it as a person, but it breaks down and it's completely unnecessary. So, what are we asking when we, like you said, such a high percentage of 16.9% of our GDP. Number 2 is 12%. Some people are doing great, way better than us with 8%. So what we're really saying, we're asking a millionaire to take a 50% pay cut. And then this millionaire is saying, I don't think I can live on that. Most people aren't buying it, right? We do have to cut costs. And if we make this, system into a person, that's kind of a person. So I think if we focus on the cost of infection, unnecessary procedures and medication, the cost of error, infections, and other things, failures of prevention, we're going to be able to do it. And I think another thing that we work with in the global work, which we should be doing, and I think we do here too, but in the global work, we all assume that one part of the problem is that people are not using the most up-to-date technologies in every area. That we assume there's a catch-up thing, which isn't always even true, but that's kind of the bias we have, kind of like what you were saying earlier, that people tend to think when we do global work, we're helping them rather than it being a two-way thing. Well, medical interventions that are best practice, for them to become practices at scale, the average, it takes about 17 years to change the system so that becomes standard practice. And it's because of resistance to change. It's because of how we implement change. Partly it's the ethics of people. Like, I know this works. You're telling me this new thing will work better. I don't want to experiment on my patient. So how do we have a system where people who we've trained, physicians and nurses, but these are mostly physician decision makers, we've trained them to use their judgment and use evidence. So when we're introducing an innovation, we need to give them the tools they need to make a decision to adopt improvements quickly. So rapid adoption of innovation and scaling change rapidly could be another huge cost saver. Sometimes the new things cost more, but a lot of times they don't. And a lot of times they're preventing progression that is really expensive. So that's another area where QI and implementation science can really be a part of the strategy, and it becomes a higher ed strategy as well as an in-service training strategy, because ideally you wouldn't wait till your hospital had a great implementation science training program. You'd learn that in medical school, or public health professionals would be engaged to provide that service. So we're assuming hospitals and have to do all these changes, but if we build it into the system, they're going to receive people who have those skills. So again, it's going to be a rough 10 years, but in 10 years you could imagine that all these pieces are fitting together with task shifting, a new scaffolding of professionals, a more informed patient and consumer and family base, more community care, and higher ed that delivers hospitals and clinics the people who are trained with the skills they need. That's not a thing you can do in 2 years, but
No.
I can't do it in 4, right? It's outside of everybody's election cycle. So we have to hold people accountable. Civil society has to hold everybody accountable to create that system. And I think in 10 years, we can be in a very, very good place, and we can be much better even in 5. It's really been an honor to be featured on the show, and thank you for the invitation. Comparative perspectives suggest better healthcare is possible. I think we can prevent healthcare problems, and we can cover most of our population, and we can save money. And I think the big word here is and. We do not have to choose between those things. We can have it all if we're willing to work together. And I am, and it sounds like you are, and I look forward to more. So thank you very much.
For more information about Lori DiPrete Brown and our podcast schedule, visit our website at edstreamp.com. Don't forget to share our podcast with your family and friends.
Thank you for listening to Getting to the Core Issues, where we bring you solutions for solving the healthcare puzzle.